Yes.
Okay, so then I'll start over again. I think it was muted. Okay. Well, welcome to everyone this afternoon for the Multidisciplinary Endocrine Conference, Endocrinology Grand Rounds. And I was just saying that before starting the program, I just wanted to announce that we had a successful match for the Endocrinology Fellowship Program. Both our fellowship slots were matched by, successfully, and we are happy to have 2 more fellows join us next year to continue their training in endocrinology. Today's speaker is Dr. Barbara Stetson, who is an associate professor and director of clinical training at the University of Louisville Department of Psychology and Brain Sciences. She has been here for 25 years. She obtained her bachelor's degree in psychology and Master of Science in Psychology, Clinical Psychology at San Diego State. Did a Ph.D. in psychology at Vanderbilt University. We have worked with Dr. Stetson for the last 25 years on several aspects of diabetes-related behavior change, depression, self-care behaviors, and she has been a great resource to us, to our fellows and training, and also to our patients. Her research focuses on the interdisciplinary aspects of health-related behavior change at the community, medical setting, and individual levels, and includes emphasis on psychological aspects of living and chronic disease, self-care behaviors, and promotion and of functional status and quality of life. As I said, she's particularly interested in diabetes self-care and education and evidence-based approaches to teaching community leaders and healthcare providers optimal strategies to promote environmental and behavioral change. So today she'll be talking to us about motivational interviewing and its use in diabetes care.
Thank you, Dr. Moksagundam. I'd say for the folks who are not in the room, if you have trouble hearing or something, please give me a shout out. And I'm glad to be back here over on the Health Sciences campus. I'm over on the Belknap campus, and so it's been a while since I've been over here. I just want to make sure that my slides are going to move forward here. It is not, Kelly, but we'll. Oh, you know what? It's not on full slide. It's not on full slideshow, I don't think. There it goes. Okay, I bet this will work now. Yeah. Okay. Sounds good. Well, so today I'm going to be talking to you about behavioral science perspectives on health behavior. So for some of you, this may be relatively new information, and some of you may be a little more familiar with this. What I'm going to be talking about is a program called Motivational Interviewing. This is an evidence-based approach to interacting with patients to try to promote and engage behavior change. So it's different than a traditional approach to interacting with patients that is a more top-down approach. So this is an approach that's based on about 40 years of data, including NIH-funded randomized clinical trials. So by the end of this presentation, hopefully you'll be more familiar with what motivational interviewing means and where it comes from. And then I'm also going to show you a couple of examples of using these techniques so that you're more familiar with techniques to be helping patients move forward with efforts to make changes. And if you're watching this and you're not a clinician, perhaps this will be of use to you in your own healthcare session interactions. So briefly, I'm going to talk about the conceptual underpinnings of the motivational interviewing approach, how that was developed in a scholarly way in the field of behavioral sciences. And then I'll go over some of these key concepts that are related to trying to get people to actually make changes in their behavior. And then I'll be sharing some resources with you and some references and things so that you can become familiar with how motivational interviewing, or MI, has been used in diabetes care. Also, a fairly large literature on motivational interviewing in diabetes care, some useful books and resources for training if this seems like something that is of interest to you. So when I talk about motivational interviewing, what I'm talking about is the collaborative interchange between patients and health providers. So my interest as a psychologist who works in healthcare settings is thinking about not just the patient and what might be going on in terms of their well-being or what they're doing, but also what the provider brings to the session. So this motivational interviewing approach has been used in counseling, it's been used in nursing, it's been used in medical care. The idea here is that when there's an interaction between a patient and a provider, it's that interaction that's pivotal for making change. So it's a collaborative approach. It's not a top-down approach that you might think of as someone coming in and being told what to do. So in terms of motivational interviewing, to move away from thinking of it as just sort of a catchphrase, this is a conceptual model, a framework that's been studied since the 80s, and it has its origins in addiction medicine from the University of New Mexico. Miller and Rolnick have 3 editions of their book. It's very popular. It's been around for a long time. And the idea here is not unlike other approaches to behavioral change that developed in psychotherapy change. And the idea is that the health provider sees patients' efforts to make changes as a process that unfolds gradually over time. So it's not an all or none event. Someone comes in and you're going to talk to them and do things in a way that's going to make them change because they're going to be enlightened and see how important it is. The idea is that it is something that unfolds gradually. This is related to things you may have heard of, such as cognitive behavior therapy or readiness for change or stages of change. And people who receive training in this motivational approach, they understand that it's a two-way street with patients and providers, right? So the idea is that you as a provider can impact a patient's resistance or interest in making a change based on what you bring to the table. And the emphasis is on collaboration. So the idea here is that a patient's motivation for making changes, and we all know that not everybody's motivated to make changes, right? Or even if they're motivated, it can be really hard. That this is a dynamic process that can wax and wane depending on all sorts of things, but it can be influenced. The other significant thing about motivational interviewing and what makes it different from traditional approaches to behavior change is there's a move away from this idea of thinking about patient non-compliance or non-adherence to recommendations to thinking about ambivalence. So the idea is that most people have some sort of interest in making a change. They just may be ambivalent about it. So in motivational interviewing, you're trying to gauge and look for ambivalence to meet the patient where they are. So you're targeting this ambivalence rather than just giving a bunch of information. So as you can see, just from the references here, there are multiple editions of the book. There, is a lot written about this change model. So the idea here is that it's not just your position as a provider, your perspective on what's important that drives the boat. The patient's perspective is pivotal. So it's really seen as a collaborative interaction. So I like this cartoon, which is sort of like a traditional approach to patient education. So the sage is saying, stop overeating, stop drinking, stop staying out late, stop fighting, don't eat sweets, don't gamble. And then he's, what did the doctor say? I have no idea. I stopped listening, right? They just tune you out. Or as, when my daughter was a teenager, la, 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 right? She just didn't want to hear. And so this is a pivotal aspect of thinking about behavior change. And you can see where this would be useful for something like addictive behaviors. And this was, really embraced early on in those circles because ambivalence and behavior change is known to be very hard. And of course, we all know that, sticking with medication, exercising, changing diet, all the things that go along with diabetes care are hard, and the patient's perspective, really matters. So starting in the 80s, I would say that you started to see a real influx in this kind of collaborative approach to thinking about interactions. Some of you may have heard of the stages of change model. Technically, it's called the trans-theoretical model. And I'll explain what that is and why it's relevant to motivational interviewing. So again, this is a conceptual model that's been disseminated in a variety of ways, and it's been dismantled, and people have really tried to study the mechanisms of action, et cetera. The idea here is, from the stages of change model, is that people may come to see you and be in need of making changes in their behavior for optimal diabetes care. But it doesn't mean that they're ready to hear what you have to say. It doesn't mean that they're going to hear what you say, and it doesn't mean that they're ever going to come back again if they're not engaged in working with you. And so the goal here is to think about what kind of readiness for making changes does the patient bring to the table, and then how do you work with that? So this was initially developed at the University of Rhode Island by Prochaska and Di Clemente to think about how to get people to move forward in psychotherapy. And it was quickly realized that this was a very useful approach for things like smoking behavior, as an example, for smoking cessation. And people began to develop all kinds of randomized trials to try to figure out how do we understand a patient's readiness for change, and then how can we kind of conceptually understand what mechanisms are most effective depending on where a person is when they come in for change. And the general consensus is that if you meet a person where they are, they have a much better chance of seeing things through in the long haul. And if they're not ready for what you have to deliver, even though it's important to you, they may not come back. They may not hear you. So the idea here is that if you start at the bottom of this spiral, and this is an example from smoking cessation literature, is that someone may be what they call in this model a pre-contemplator. That is, they aren't even thinking about quitting smoking. They have zero plans to quit smoking. And many people now who smoke cigarettes, who smoke multiple packs, they've been smoking a long time. They're not really ready to do that. And so if you come in and start, providing a whole lot of information about what to do to quit, you may lose them in other areas because they're not ready. I have no plans to quit. Moving up, if you think of this in a ladder that's not static, kind of a continuum, is that some people are thinking about it, but they're not doing anything about it. So they're contemplating, right? I'm thinking about quitting smoking. I know I need to, but I'm not quite there. Well, that's great. It shows that there's some ambivalence there. It's not that they're not adherent per se, but there's something going on that makes them think about it a little. And there's some things going on that make them not ready to change. But if you can hit them where they are, that can move them forward. Another way of thinking about the next phase is that someone may be contemplating change and they may be getting ready. They may, have decided and made a declaration to their provider or to their family that they're quitting smoking. They might have gotten a script, to try to help. They may have purchased nicotine gum. And these levels of readiness may change. You get a chest X-ray and there's some concern. There's a spot that may move you rapidly from pre-contemplation to contemplation, right? It can happen for a number of reasons. You have grandchildren, you want to spend more time with them, you want them to come over. And then another way of thinking about another phase is action. That is, you've set a quit date, you've stopped smoking for a week or two, and you've removed the ashtrays from your car. You've cleaned it out. You don't have any packs of cigarettes in the house. But that doesn't mean you're going to stick with it, right? So the key in this model is, can you get someone to maintain that change? And so the idea is that different strategies could be matched to different stages of change. There are a lot of trials. A classic randomized trial for helping patients reduce their cholesterol levels and blood pressure is the WATCH trial. That's the Worcester area trial of counseling for hyperlipidemia done at UMass. The PACE trial, many iterations of PACE, which is physician-assisted counseling for exercise, been done and had pretty good results, better than traditional counseling approaches. So moving forward, the motivational interviewing approach is related and contiguous to the stages of change, but it doesn't necessarily assume that there's a completely matched trial. It can be done more informally in a practice setting. So the data suggests there are a lot of things that help and hinder patient efforts to change. So many providers might assume in a traditional approach that people don't make the changes that they want them to make because they're non-compliant or they don't know what to do or they don't care. The data suggests that the reason why people actually change is when they're ready, if their values support it and they think it's important, if they think the cost and benefit ratio suggests that it will be worth it, they have enough self-efficacy to overcome obstacles so they think they can do it. Again, the pros outweigh the cons, and then they have adequate support socially in their environment to do it. So if you think about motivating a patient to change, if you think about those whys, that can be very helpful. So importantly then, with this motivational interviewing approach, the perspective is to identify ambivalence, not bad patient, non-compliant patient, but what's going on here with ambivalence, and then to view it as a collaborative effort to meet the person where they are. So being ambivalent is seen as a normal part of change. Change is hard. I mean, I think almost everyone has tried to exercise at some point or eat healthy all the time, and, life gets in the way and it's hard. Ambivalence is normal. But if someone is even a little bit ambivalent, it indicates there's potential for change, and that's what you go for, because in the long haul, you want somebody to come back, right? The idea here is using a session, even if it's 15 minutes long, to resolve discrepancies between where the patient is thinking about what might be feasible and where they are now. And the focus is not on scolding or lecturing or giving a bunch of facts to people. It's talking about change and focusing on that. So the idea of an interviewing approach, which means that you're collaboratively talking with the patient, is that you are thinking about discrepancies and ambivalence. Those are the things that you're targeting. So what's different about this approach is that your job is less to worry about being someone who is figuring out all the solutions and doing all the work and having the patient do some more work. You're more like a guide here. So that's the focus. So you help a person to identify ambivalence and just gradually move towards change. So if you look across the bottom of this figure, you can see that on the left we have these ideas of moving on a continuum from not thinking about change to actually doing it and sticking with it. And to think about ambivalence, you think about, well, what are the patient's values? What are their concerns? What are their priorities? How can you get them to talk about change from their perspective so that they're engaged? And you also kind of think about how to make sure that they're confident. So you can even ask the person, well, we're talking about some ideas for change. How confident are you that you could actually do this? Tell me on a scale from 1 to 10. And that gives you an idea of kind of where they are. And then you can think about a plan for change and support change in a way that is salient, from their perspective. So the idea here is if you go about things in the same old traditional way, you'll probably get the same old traditional results. So you want to maybe aim for something different. So what is the purpose of the interaction of the session? It's not just to give a bunch of information. It's to create a dialogue so that it's an exchange. And what you're doing is that you're letting the patient know that they're a partner here. It's not a top-down approach. So this is pretty different than a traditional approach, is that you actually ask permission. Would it be okay if today we talk about, how things are with your weight? Would that be a topic that we could talk about? That helps you get them engaged. You're meeting them where they are. That's a big take-home point. Ask permission, meet them where they are. Yes, you are the expert, but you're trying to minimize the power differential so they are engaged and they don't, plug their ears and they don't leave. Typically, people who have gone through a lot of training with motivational interviewing are very used to things like giving them options. Here are some things that we could talk about. Which one do you think would be the most appropriate today? As a way of kind of moving them along that continuum. So your job as a clinician in a session is to understand where a patient is in terms of change. How important is it to them? What is their confidence in their ability to change? Not everything, but something. And you can kind of see, is this a proximal goal? Is it immediate or is it kind of down the line? Is it distal? And then the way you do this is you try to engage them so you don't lose them. You get them to focus on something specific, and then you try to evoke some kind of motivation, and then you negotiate plans. So again, the distinguishing characteristic here is that the traditional approach is pretty directive. Person comes in and you say, if you don't stop smoking, you're going to, have lung cancer. I'm worried that you're going to have COPD or need to go on oxygen. They're confrontational. And they might provide them, this is what you need to do to quit smoking. You need to do it this way now. And so from a patient perspective, that might be viewed as coercive and sort of system-driven. They're not part of the process. And again, we're talking about an approach that uses this spirit of, the spirit is to not be confrontational. Of course, people need information about how to make changes. Patient education data suggests that patients can remember on average 3 things max. So more than that is just, too much. So motivational interviewing is more, guiding, right? You're not completely following the patient's lead. It's collaborative. You're a guide. It's a partnership. You accept where they are. You are compassionate. You try to validate, even ambivalence is a positive thing. Some validation, or else why would they come back if they're miserable? And then you try to evoke change. So I have a couple of video clips I'm going to show you so you see what I'm talking about. And these are standardized training clips that come from a number of physician training trials. So those of you who are at home, if you have trouble with the audio, let us know. We tried to work to make sure that this would be something that could be heard both in the room here where we are and then remotely. So this is an example of an ineffective traditional approach to try to move someone forward with behavior change. So this is a physician who is interacting with a mother of a child who has recurrent ear infections, and the provider has learned that the mother smokes and is really frustrated. And she knows that this is not a great idea with a parent of a kid who has asthma, and she's frustrated. And you'll see in this video that she has really good intentions for the welfare of the child and the mother, but it's a very traditional approach that doesn't look like it's going to result in behavior change. Let's take a look. It starts out with a little music and some, not exciting talking, but then it is a vignette that I think you'll find pretty useful.
Doctors, nurses, and physician assistants all have opportunities to counsel patients about health-related behaviors. As a medical professional, you have a responsibility to talk to your patients about tobacco use and how it affects their health. At times, you will also have a responsibility to talk to them about how secondhand exposure to their tobacco smoke affects other people's health. These can be sensitive topics, and it is important to keep in mind that the way you approach your patients about these issues will have a big impact on how your advice and concerns are received. In general, it is not useful to confront or scold your patients about their tobacco habits, as that approach is usually not well received by patients and may interfere with your ability to counsel them effectively. Watch what happens as this provider becomes more and more confrontational in her warnings about tobacco use and her advice to quit smoking.
Okay, so I wrote a prescription for an antibiotic for Aiden that should help with the ear infection, but in looking through the chart, I mean, it seems like he's had 6 or 7 of these just in the past year or so.
Yeah.
That's really a big problem.
Yeah, it's pretty stressful for both of us. He gets really upset.
Well, one of the primary risk factors for multiple ear infections in kids is actually smoke exposure. Are you smoking?
Yeah, I do smoke, but I don't smoke around him. I try really hard not to smoke around him.
Well, the fact that he's having these ear infections is indicating to me that he is being exposed to smoke. And so what can you tell me about that?
I don't know. I mean, I try really hard not to smoke around him. I don't smoke in the car. When he's home, I go outside to smoke. I know it's bad, and I know it's bad for him, so I don't want him to be around it, so I try really hard.
I really need you to quit smoking, both for your health and for Aiden. Did you know smoking around your child is associated not only with ear infections, it could get to the point where you have to put tubes in his ears pretty shortly here, but also things like vitamin C deficiency, cavities, like dental cavities, behavior problems, asthma, other upper respiratory infections. It's really putting him at a lot of risk. In addition to that, kids of smokers end up smoking themselves. Do you want him to grow up to be a smoker?
No, but I don't smoke. I've thought about quitting, but it's really hard, so I just don't know how to do it.
Well, now's the time to quit. It's really gotten to the point where you can't keep smoking. Not only for him, like I said, but also for you. You're putting yourself at risk for lung cancer, for emphysema, for oral cancers, for heart disease, for all kinds of things.
I know. I've heard. People have told me before. I've heard all that. I just don't know how to do it. How am I supposed to quit? It's so hard.
Well, there's all kinds of things you can use now. It's not as hard as it used to be. You can use nicotine replacement. There's patches, there's lozenges, there's gum, there's the inhaler, there's nasal spray. We can talk about medications. You can try Chantix, you can try Zyban. There's quit smoking groups you can go to. There's hotlines you can call.
I just don't have time
There's
for
no
any of
reason
that.
why you shouldn't be able to quit. This is really important.
I understand that. I know it is. Everybody has problems, right? It's really, really hard.
Well, what can be more important to you than the health of your child?
I don't know.
I really need you to tell me that you're going to quit smoking. This is really important.
I'll go look at all those things and I'll find. I guess I'll try to find something and I'll talk to my doctor about it.
Okay, well, I think you really need to think about this seriously. Like I said, it's really putting yourself and your child in danger.
Okay. Whatever. Okay.
Okay.
By starting the interaction with an accusatory question, "Are you smoking?" the provider immediately put this parent on the defensive and minimized the likelihood of a productive discussion. She then proceeded to lecture and scold the parent repeatedly, while ignoring the parent's multiple remarks regarding her low confidence in her ability to successfully quit smoking. Once the parent felt completely defeated, she caved in and announced that she would quit smoking. It is clear to any observer that this parent had no intention to quit smoking at this time, but rather that she was simply attempting to bring an end to the uncomfortable confrontation. In this case, the provider wasted an excellent opportunity to work with a mother who was expressing a real desire to quit smoking, coupled with a lack of confidence in her ability to do so. By listening to what the parent was really saying, the provider might have been able to help this parent develop a workable plan. In addition, both the provider and parent would have felt more satisfied with the interaction.
Does that seem like a familiar scenario in some way? I could get this to slide for me here. There it goes. So you get the idea here. It was a perfectly nice physician who was saying, perfectly valid things, but it put the mother on the defensive, and she said what she wanted to hear. And so it escalated quickly because she wasn't focusing on what the mother was saying. So those of you in the room here, what do you think the mother was saying that indicated some ambivalence? Doesn't smoke around the baby.
Yeah, and she's tried and
It's hard. I mean, what I heard was like, this is so hard. She threw her bone. This is hard. But the physician had an agenda, and she kept saying, I need you to do this, right? This was the provider show. It wasn't collaborative. So, this is an example that, arguing and accusing or putting someone on the defensive, it's not helpful. And that's not uncommon with things like, exercise or weight or smoking. Those are tough areas, alcohol. The idea here is lecturing versus listening. By listening, you can pick up on those things. You could see the ambivalence as a sign that she was actually contemplating change. So this was the provider perspective. There were missed opportunities to talk about why it was hard and behavior change, missed opportunities for collaboration. So they were both discouraged, and the mother just sort of was like, yeah, she checked out, basically. So if you were going to go with the principles of motivational interviewing here, you would think about expressing empathy, and you would try to understand current behaviors, where they are now, not just your future goals. Where she is now is she could probably have made some steps to move to prepare and into action. So there was some resistance here, but it's just the mother was explaining, I'm not non-adherent. I mean, I'm not trying to resist. And the idea here with a provider is, you may have heard this phrase before, roll with the resistance. So if they're resistant, you roll with it. Okay, this is hard. Let's talk about that. And then you support their self-efficacy or their confidence for overcoming obstacles. You can assess that. So in a mnemonic for motivational interviewing, for using some of these approaches to express empathy and connect, is ORS. So one is you ask open-ended questions. So, you're not smoking, are you? Is not an open-ended question. An open-ended question would be, you would provide opportunities for elaboration. A would be for affirmations. That is, you validate some aspects of what the patient is saying to help engage them and move them along, increase the rapport and connection that you have. You use reflections. You reflect back what the person is saying so that you make sure that they get that you heard them, you understand what they're saying, and then you summarize where things are so that it's not an overload of information. So we're going to watch this again with the same provider using these techniques. So same encounter, and what I'd like you to look for is this listening and motivational approach as opposed to the top-down arguing, using open-ended questions instead of closed questions, etc.
Watch what happens this time when the provider cues into what the parent is saying, empathizes with her situation, and attempts to work with the parent to find a solution that fits her needs.
So I wrote a prescription for antibiotics for Aiden.
Okay.
I did want to talk to you, though. I'm a little bit concerned looking through his chart at how many ear infections he's had recently, and I noticed that you had checked the box that someone's smoking in the home. So I was wondering if you can tell me a little more about that.
Well, it's just me and him, and I do smoke. I try really hard not to smoke around him, but I've been smoking for 10 years, except when I was pregnant with him. But it's so stressful being a single mom and having a full-time job, and so that's why I started smoking again.
You have a lot of things going on, and smoking's kind of a way to relax and de-stress.
Yes, yeah. Some people have a glass of wine, I have a cigarette.
Sure. And it sounds like you're trying not to smoke around him. Why did you make that decision?
I know it's not good for him. I mean, I've read those things about ear infections and asthma and stuff, but other kids have ear infections and their parents don't smoke.
So on the one hand, you're worried about how your smoking might be affecting him, and on the other hand, you're not so sure if it's really the smoking that's causing these problems.
Right. Yeah. I mean, he doesn't have asthma. He hasn't had a lot of other problems that his other friends have. So, and I've thought about quitting before in the past, but I just don't see how it's possible right now.
What made you decide to quit smoking when you were pregnant?
Well, he was inside me and we were sharing everything, and I knew that he would get some of that, and I just didn't think I could live with myself if something happened to him.
Right now, though, it feels almost too difficult to even manage or even to try.
Yeah, exactly.
How were you successful when you quit before?
I don't know. I think about it now. I don't even know how I did it. I just did it. You know, I just couldn't imagine like him not being born or going into labor early and him having problems and stuff like that, all the stuff that they talk about with women who smoke. So that was just enough to say, okay, you know what, I'm not going to risk that.
Mm-hmm.
So
the risks were so scary then that you were able to stop, but
yeah.
They don't feel as scary to you now.
No, I mean, we're two separate people, and like I said, I try really hard not to smoke around him. I'm pretty good about that. I don't let other people smoke around him. So
You're doing the best you can do.
yes. Yeah.
Okay, but it sounds to me too like part of you really does want to quit.
Yeah, I know that I need to, and I keep every new year I say, okay, this year I'm going to quit smoking, but then something happens and it just doesn't.
It's
and
on your
quitting
to-do
doesn't
list,
happen.
it's just not making it to the top.
Yeah.
If you did decide to quit, on a scale of 1 to 10, where 1 is not at all confident, you don't think you could do it, and 10 is you feel pretty certain that you could, where do you think you fall right now?
Probably like a 5. Kind of in the unsure area. Like, I know I've done it before, so I know I can do it, but at the same time, it just seems really hard, and it's not the same situation.
Well, what made you say 5 rather than 2 or 3?
I know all the ways it's bad for me, and I don't want him to grow up thinking that it's okay to smoke. I don't want him to use any kind of, I don't want him to chew or anything like that. So I know I need to, especially before he gets old enough to understand what mommy's doing, but I just don't know if I can do it.
Okay. So it sounds like you have a lot of reasons why you'd like to quit. You have been successful quitting in the past, and right now you're just feeling a little bit hesitant about your ability to do it.
Yeah.
Where do you think we should go from here?
I don't know. I'd like some help. I just don't know what kind of help I need.
Sure. Well, if you'd be interested, that's something I can definitely talk to you about. There are a lot of new options that can actually help people be way more successful in their attempt at quitting. There's different medications you can try.
I don't like medicine.
Okay. There's also a lot of support groups and classes that you can take where you have other people to go through it with you, and sometimes just having that support can be a big part of it, especially for people like you where smoking is such a stress reliever.
That sounds nice, but I'm not sure if I have the time for all that.
Sure. It feels like something that would take up a lot of time and maybe not fit into your life. I wonder if we could talk about some options that might fit into your life.
That would be really nice.
Okay, well, if you're willing, then we could set up another appointment where you could come in and we could talk more about that.
I would like that. That would be great.
Great.
Thank you.
Sure.
This time, the provider had the same agenda, to talk to this parent about the dangers of secondhand smoke and to counsel her to quit smoking. However, this time the provider's focus was on the parent's own view of the issue. By giving the parent an opportunity to reflect on her situation, the provider was able to elicit reasons for change from the parent herself. There was no need to lecture or scold because the parent was making her own case against smoking. Many times, our patients already have the information that we try to give them. What they really need is someone to listen to them and to help them sort out a plan that will fit in their life. By accepting and respecting our patients, even with their faults, we communicate our genuine desire to help them make positive changes in their lives. During this interaction, the provider demonstrated that she understood the parent's struggle and that she still wanted to help. As a result, this single parent found she finally had someone on her team. This increased both her interest and willingness to try working further with the provider to find a solution that would fit in her life.
hopefully you could see the effort to use some of those techniques there, right? She was much more engaging. Many people will talk about the motivational interviewing approach being, 2/3 listening, 1/3, talking. So that the idea here is you're not rushing to fix everything, which is often what happens with clinicians. They really worry about things. And the best way about not doing enough, the best approach to elicit information is to ask those open-ended questions. So, could you tell me more about that? Could you explain that? So the focus is on the why, not necessarily on the how. So that's a distinguishing characteristic. You also affirm the patient perspectives and you express empathy to get them coming back. So rather than being confrontational here, the provider was able to say, it's really hard. It's one more thing to do. You were so motivated, before because the threats seemed really real, and now not necessarily so much. We can see where that is hard. So it's collaborative. So again, the example here showed that she was listening and she was reflecting back what she heard, and that gave the patient a chance to say, yes, it's this, or no, it's not that. And the focus was on change, not necessarily like factual how to do this or that. She tried to clarify with questions, and then she did that self-efficacy rating on that 0 to 10 scale. And it was noteworthy that she said, 5, which of course shows ambivalence, right? Or she's contemplating change. But she didn't say, well, why not a 9? Why a 5? Why not a 9? She said, why not a 2 or 3? Because she was focusing on the positive aspects of change from the patient's perspective. And at the end, she tried to summarize and then link it back to the examples and then check in to ask permission and then set up another appointment to talk about a plan. And it takes another session, but there's a better chance that the person's going to come back and actually be interested and hear what she has to say. So in wrapping some things up, now that you know about what we mean by motivational interviewing and the conceptual approach and how you do it, I should mention that there's really good evidence for motivational interviewing in diabetes care. The NIDDK site actually has a page devoted to motivational interviewing. There have been a number of trials, including things like weight loss and dietary change and type 2 diabetes using motivational interviewing, randomized to compared with traditional approaches. So there is data. To highlight here, there are several systematic reviews and meta-analyses already. So there have been enough studies to accrue data across randomized trials. And you can see that this first systematic review looks at randomized controlled trials, looking at motivational interviewing compared to another intervention on things that you all would really be interested in, like diet change, exercise, smoking, and weight loss. And the biggest changes that were identified in this systematic evaluation across studies is weight loss and diet change. And then also some trials focused specifically on physical activity, which is often down the list for patients, behind diet and medication adherence. So moving down to these other behaviors has been shown to be feasible with motivational interviewing. If you're interested in this approach, I do have some recommendations. The most recent edition by Miller and Rolnick, the people who developed this, who have lots of data, was published in 2013. It's a little paperback. You can get it at Carmichael's or on Amazon. And then there's a pretty recent book on motivational interviewing in diabetes care, and I've read this book, and it's pretty helpful. I mean, it's got some concrete tips. It's got examples. It talks about things like group approaches, or when patients have depression. And the first author, Steinberg, I think he has diabetes, and he's a retired physician. He might be a primary care physician. And then William Miller is of the Miller and Rolnick, the originator. So it's really well done. And if this floats your boat, you can get online training besides going in person if you would like to know more. Mint is the network of motivational interview trainings, and they have a ton of stuff on their website, all kinds of guides, journal articles, videos. That's where I got these video clips. And the University of Utah has a training program that's online for using motivational interviewing in primary care. They've got a lot of journal articles, something for your journal club if you have that. So, you know, there are resources if you would like to know more about it. Thank you very much for your attention. I know that some of you are getting CEs for this, so here is the event code. And I'm happy to take any questions either here or if I'm able to get the chat. Yeah.
That was excellent, thank you. You need to, unshare this.
Unshare? Okay.
Up there.
Is that it?
Yeah, you already see it.
Oh,
Yeah, the red.
okay. I see it. Okay.
I have a
So,
question.
yeah, Dr. Krishnasamy.
That was really a good. One question. Time management.
Yeah.
You know, when I was looking at that, which is great. I mean, I wish like if I had more time to spend, and sometimes you have patients waiting and there's reviewing their meds, their thing, and what is formulary, what is not. There's so much.
Yeah.
And many times the 1 or 2 minutes you spend asking them or telling actually makes lightens up and ask, you know, is there anything, any techniques where there's like party lines that you use for time management?
And let me reiterate that for the people who are online. So
Sure.
Dr. Krishnasamy asked about the time management issue that we all face of, you know, what do you do when you do need to provide prescriptive information that they're looking for? Are there any tips? And I would say that book has tips that can be helpful. You have to focus. The tip I have is to focus. You just can't be everything in one session. And I know you very well that you know, have the best of intentions and, you know, really want your patients to be able to do lots of things. And you have to meet them where they are. Some people are able to handle a lot of information and are ready to do that. And for people who are already kind of in an action phase, I think you could give them more. But if there are people who are really ambivalent or maybe they aren't going to retain that much information, one has to resist the urge to provide all that and back up. And, you know, if you're able to use a diabetes educator's time, you know, afterwards to provide that information, give them something in writing, you know, so they have that, because people really are different. But yeah, everybody's different. But I think what the trainers would say is focus. Try to focus in on, you know, whatever the you have to prioritize, you know.
Usually we address one change.
Yeah, maybe so. Maybe so. Yeah.
These days it's vaccine, you know.
Oh, yeah.
When you're talking about this, and
I'm glad that you brought that up about vaccines. So Dr. Krishnasamy, for those of you online, mentioned, you know, prioritizing and vaccines. So I can tell you that the Centers for Disease Control has a page on motivational interviewing about vaccines. And so I'm sure somewhere someone's going to publish a paper pretty soon about MI approaches for vaccine. Although we've shaken things out, you know, as we all know now, where it's sort of like the hardcore cigarette smokers of the people who aren't getting vaccinated at this point have lots of, you know, cognitions and emotions. Yeah, there are some. Have some cognitions and emotions associated with that. So I see. So someone actually has asked that, a vaccine hesitant person. So I think that what you would need to do is try to look at their personal reasons for hesitancy. Right. I mean, it's interesting that, you know, now that health providers are required to get vaccines in some settings, that's been enough to nudge them along to be able to say, well, I can save face with people around me who are not supporting vaccines because I have support in my workplace. And, you know, some side effects like metformin have caused lethargy. How can you motivate a person with lethargy? Well, I think that's a difficult one. So if I would want to know more about the lethargy. So is it comorbid with depression, for example? And can you do a brief assessment, say, with the PHQ-9 to try to see whether that's exacerbating it, and then talk to them about those symptoms? Could you talk to them about their routine? So if it's lethargy about physical activity, maybe there's something about waiting to the end of the day that is less efficacious than fitting it in at the beginning of the day. I think that's an excellent question. Motivational interviewing has been used with older adults as well who might have lower energy levels, and it can be effective. You need to focus on the positive aspects, and encourage small steps, I would say.
Multiple, you're seeing different people at work or something.
Oh, that's a good point. Dr. Mokshagundam asked, what about continuity and provider versus seeing different providers? I think having, and I don't know whether you're talking about an interdisciplinary team or whether you're talking about different, endocrinologists or et cetera. But
both of them, because sometimes.
Yeah. That's tough. Yeah, a collaboration for the win, right, between providers. I mean, if you're able to have interdisciplinary, team meetings, with everyone using Blue Jeans and Zooms and Microsoft Teams now, perhaps taking advantage of technology to have conferences where everyone's on the same page is the way to go. When providers are working in isolation, I think that it can undo your hard work. Someone else gets discouraged. Thanks for the motivation. Hopefully this has been motivating. Happy to take any other questions.
What do you do when someone do great for a year?
Yeah. Dr. Mokshagundam asked, what do you do when someone's done great for a year and they get their A1C down and then they come back 6 months later and it's 9 or worse? I'd say you dial it back to the beginning, and if you think about that stages of change sort of as a dynamic wheel, I think you would move back down. They're probably contemplating that change and ambivalent, and you think about what worked before, sort of along the line with the smoking. It does take that the idea of 6 months being necessary to have permanent change is a little bit arbitrary. It comes from, some data. If you can get someone to make a change for about 3 months, that really is something to reinforce like crazy, because it does help, strengthen that motivation. But, I don't necessarily floss my teeth every time, even though I have the best of intentions, and it may be because I'm busy or, things come up with exercise, and you start back with what are the barriers, what can we do to make it more convenient.
So are there alternative approaches for them with the patient? Or I tried that before and it didn't work. I ended up here. Can I try something?
Trying something else. There is a school of therapy approaches that's also from the addictive behaviors that's related to all of this, called relapse prevention training, and the whole focus is on the action of relapse. Just with a diet and weight loss, and with smoking and alcohol use, it's one thing to get people to change, but maintaining that change is the hardest part, right? So building that in with other social supports and giving them a toolbox, if you will, to draw from is particularly helpful. And I think having interdisciplinary teams really makes a difference as well. Yeah, Satya.
I was seeing in the commercial, there was.
Yeah.
Is it something, have you looked at?
I've heard about it. Dr. Krishnasamy is asking about Noom for weight loss. I've heard good things about it. I don't know so much, but
I didn't know the content.
So a friend of mine who is a health psychologist has gone on that and talked about how it uses behavior change principles, and it's supposed to be pretty good because it uses a gradual, approach. And I think there are built-in supports because it's online. Try to make it easier, and they look at barriers and things like that. So personally, I don't know much about it, but I have heard positive things about it, and I've heard positive things honestly about Weight Watchers. Because of their social support. It's not like back in the old days they used to make people get weighed publicly and shame them and things like that, which is terrible. Who wants that? But I think that they're a long way from those days in terms of, having a graduated approach and behavior change principles. But I think Noom is often viewed as the new Weight Watchers, because it's a social component and it's graduated and it's,
The commercial was very.
Yeah.
I was thinking I should ask somebody.
Yeah.
The commercial talks about it being a behavior.
That's what I've heard. I'm happy, I correspond with you. Sometimes I'm happy to, look into, but anecdotally, I've heard that it seems reasonable. And there are, websites through certain organizations like the Society of Behavioral Medicine and then, NASO and things like that have evidence-based approach information. Oh, yeah.
It's a huge. I almost feel like
weight loss with the pandemic is tough.
How do you help? Where do you start?
Well, so 50 years of data on maintenance of weight loss, because people know how to lose weight, right? It's maintaining it. There are two things that consistently are associated with long-term maintenance of weight loss. One is writing things down, keeping a record of what you eat, or exercise, and exercise. Exercise is one of the number one things associated with maintenance. Maybe because you're already monitoring, your behavior in addition to the expenditure, and of course that is super helpful for glycemic control, et cetera. But exercise and self-monitoring, beyond the metformin and other things.
Or whatever.
And Dr. Kotwal said that they think a hybrid of traditional and motivational may have good outcomes too. I would say it depends on the patient. The scolding, so it depends what you mean by traditional. Scolding is never good, but disseminating information is useful.
What's the role of peer support?
What is the role of peer support? I think it's really pivotal. Although there is data suggesting that for men, peer support can derail diabetes care, and there are gender differences in the literature for that. So I guess it depends who your peers are and in what way they're supporting you. Yeah.
Because one of the problems from a practical point of view, question is, support groups where there are peers. Mm-hmm. How do we maximize coach?
Mm-hmm. There's a program in the School of Public Health at UNC Chapel Hill called Peers for Progress, and they have done international studies focusing exclusively on peer support for lifestyle change, which is interesting. It's Ed Fisher. I don't know if you know who Ed Fisher is, but he's the dean of the School of Public Health. And he's a psychologist who is in public health, and he's gotten this big interdisciplinary program. I think the American College of Physicians funds grants. That's a good resource for sort of how to, but the data suggests that the peer interventions are cost effective and useful. They're really big in like HIV risk reduction, for example, where peers are able to connect better than providers, but there's input with providers and, teams. Yeah.
But I haven't really looked at it.
Yes,
common things
PTSD and things like that.
Oh, yes, absolutely. PTSD, there's very good data for that, the VA.
Columbus, they have diabetes.
I think group classes are terrific because there's modeling and it can be effective. Just like the diabetes camps for kids, that's a great way for kids to learn about what to do.
Place to experiment new.
Yeah.
Jump in and volunteer.
Right. Well, thanks very much for listening, folks. I enjoyed being here. Thanks for those of you online.
Motivating
Hi,
us.
Cooper.
Right before